right, we got Varcarolis, Psychiatric Mental Health Nursing, 8th edition, Chapter 25, Suicide and Non-Suicidal Self-Injury. Key terms and concepts: completed suicide, copycat suicide, lethality, non-suicidal self-injury, Post-Vention, primary intervention, psychological autopsies, suicidal ideation, suicide, suicide attempt. A tribute to Adam Hall on the first anniversary of his death from his loving mother, July 1st, 2014. Dearest Adam, it's hard to believe that a year has gone by. The void created by your departure fills me with such emptiness, while echoes of your laughter linger, urging me and those whose lives you touched to press forward, living life to the fullest, seizing and celebrating each moment. I'm so grateful to have been blessed with a son such as you, 26, almost 27 years, for so fleeting a time. Over in what seems to have been a heartbeat, I purpose my life towards building your future, creating possibility in your life, living vicariously through you, as you often expressed. So many questions remain. Golden moments flash across my mind. Your warmth, your charm, the love you shared, the depth of your character, the contagious ardor with which you embraced your passions. Impossible to capture in mere words. You were loved, adored, and admired. You were so ardent and able. I was so proud of you and cherished you with all my being. Love, Mom. Suicide is devastating for those of us who lose a family member or friend. What brings a person to such a drastic and permanent solution to life's problems? As unimaginable this act is to many of us, a human life ends every 13 minutes as a result of suicide, leading to the loss of approximately 113 of American lives daily. Suicidal ideation is thinking about personal death, including the wish to be dead, considering methods of accomplishing death, and formulating plans to carry the act out. Suicide is the intentional act of killing oneself by any means. A suicide attempt is actually carrying out an act or acts with the intention of death, which may or may not prove fatal. A completed suicide is one in which self-injurious acts committed by an individual results in death. As healthcare workers and clinicians, our interest is in preventing these suicides. Suicide is largely preventable and should be considered a never event. Yet too often, we direct efforts only towards individuals who are at immediate risk. In the year before their deaths, 83% of individuals received either inpatient or outpatient healthcare services, and approximately half of those who died by suicide did not have a mental health diagnosis. It is critical for healthcare workers to be advocates for this problem and to mobilize the community to reduce factors that may contribute to suicide. In the American Psychiatric Association's DSM-5, the focus on suicidal ideation and behaviors has been increased. Characteristics that make people more vulnerable to risk for suicide are identified throughout the manual. In addition, Section 3 highlights disorders that require further study. Suicidal behavior disorder is among the disorders in this section. In this chapter, we will include the criteria for this proposed disorder. We will also review facts about suicide, discuss assessment and care of patients who may be suicidal, and address the needs of patients' families. Another disorder included in the DSM-5 for further study, non-suicidal self-injury, will also be discussed in this chapter. Epidemiology. According to the CDC, nearly 43,000 people died by suicide in 2014, making it the 10th leading cause of death in the United States. In 2014, suicide was the second leading cause of death for 10 to 34-year-olds, the fourth leading cause of death in 35 to 54-year-olds, and the eighth leading cause of death among 55 to 64-year-olds. In 2014, attempted suicide or suicidal ideation led to approximately 470,000 annual visits to the emergency room, and outcomes may be catastrophic for the individual. Consider the case of a young man with schizophrenia with deep depression and confusion. He takes a medication overdose and kneels down in front of his couch to pray for forgiveness as he dies. His father finds him near death and calls the paramedics. The young man lives, but due to being in the kneeling position for so long, the circulation to his legs was severely compromised. This compromise resulted in amputation of both legs and a lifelong physical disability. It is important to consider that the number of suicides may actually be double or triple those reported due to underreporting in general. Purposefully steering a car into a bridge abutment and crashing may look like an accident. However, many reported accidents, homicides, and deaths ruled as undetermined are actually suicides. The military is increasingly concerned about suicide rates among enlisted service members and veterans. Until recently, service in the military was a protective factor for suicide. However, since 2008, suicide rates among active duty service members has increased and surpassed rates of civilians. Suicide rates among veterans are also increasing at higher rates than among the U.S. general population, especially for women. Box 25.1 is called Suicide Facts. General, suicide is the 10th leading cause of death for all ages. The National Violent Death Reporting System examined toxicology tests of those who have committed suicides in 16 states. 33% tested positive for alcohol, 24% for antidepressants, and 20% for opiates or prescription painkillers. Gender statistics. Males take their own lives at nearly 4 times the rate of females and represent almost 78% of all U.S. suicides. During their lifetime, women attempt suicide 2 to 3 times more often than men. I had to let that little paradox sink in there for a second. Suicide is the 7th leading cause of death for males and the 14th leading cause for females. In 2014, men had a suicide rate of 20.7 and women had a rate of 5.8 per 100,000. Firearms were the most common method of death by suicide, accounting for a little less than half, 49.9% of all suicide deaths. Next most common methods were suffocation, including hangings, at 26.7%, and poisoning at 15.9%. Racial and ethnic statistics. Among American Indians, Alaska Natives aged 10 to 34 years, suicide is the 2nd leading cause of death. Suicide rates among American Indian, Alaska Natives, adolescents, and young adults aged 15 to 34 are 1.5 times higher than the national average for that age group. Of Hispanic students in grades 9 to 12, significantly more Hispanics, 11.3%, attempt suicide than black and white students. Age statistics. In 2013, 17% of U.S. high school students reported they had seriously considered attempting suicide during the last 12 months preceding the survey. About 8% of students reported they had actually attempted suicide 1 or more times during the same period. Suicide is the 3rd leading cause of death among 10 to 14-year-olds. Suicide is the 2nd leading cause of death among 15 to 34-year-olds. Suicide rate for adults ages 75 years and older was 16 per 100,000. Attempted suicide. In 2013, nearly 836,000 people were treated in emergency departments for self-inflicted injuries. There's 1 suicide for every 25 attempted suicide. Comorbidity. Suicidal ideation is a result of inner pain, hopelessness, and helplessness suffered by individuals. Psychiatric disorders are risk factors for suicide because these disorders are present at the time of 90% of completed suicides. Depression is the diagnosis most commonly associated with suicide, and approximately 50% of those who completed suicide are experiencing depression at the time of death. Patients diagnosed with anorexia nervosa and post-traumatic stress disorders are also at greater risk for suicide. Lost relationships, financial difficulty, and impulsivity are also common in this population. Individuals with a diagnosis of schizophrenia have an 8-fold increased risk than those in the general population, especially during the first few years of the illness. It is the leading cause of early death in this population. 20% of patients diagnosed with schizophrenia will attempt suicide at least once. Up to 13% of these people die from suicide, usually related to depressive symptoms rather than to command hallucinations or delusions. Patients with substance abuse disorders who use both legal and illicit substances have a higher suicide risk. Years of substance use and comorbidity with depression are factors associated with increased risk. Many individuals who die by suicide have alcohol in their blood at the time of death and have used an illicit substance in the days before their death. Alcohol, a depressant, tends to dull one's senses, and individuals who are otherwise ambivalent about whether to end their lives may act on suicidal thoughts. Drugs and alcohol increase the risk of suicide by decreasing inhibitions, increasing aggressiveness, and impairing the individual's judgment. Using both cocaine and alcohol simultaneously is a particularly deadly combination. Table 25.1 identifies the percentage of suicides attributable to psychiatric disorders. We can look at that later. Risk factors, biological factors. Suicidal behavior may run in families. Margot Hemingway's death in 1996 was the fifth suicide among 4 generations of writer Ernest Hemingway's family. Twin and adoption studies suggest genetic factors in suicide. Concordance rates are higher among identical twins than among fraternal twins. Recent studies indicate a combined effect of genetic and epigenetic factors. Gintivano and colleagues found that the SCA2 gene expression was lower in individuals with suicidal ideation. This lower gene expression, along with anxiety and stress, could account for about 80% of suicidal behaviors and the progression from suicidal ideation to suicide attempt. These findings are consistent with the diathesis stress model or the dual risk hypothesis. Low serotonin levels are related to depressed mood. Studies have found low levels of serotonin or its metabolites in the cerebrospinal fluid of patients who are suicidal. Postmortem examinations of individuals who complete suicide also reveal low levels of serotonin in the brainstem and or the frontal cortex. Psychological factors. Sigmund Freud originally theorized that suicide resulted from unacceptable aggression towards another person that is turned inward. Carl Menninger added to Freud's work by describing 3 aspects of suicidal hostility: the wish to kill, the wish to be killed, and the wish to die. Aaron Beck identified a central emotional factor underlying suicide intent: hopelessness. Cognitive styles that contribute to higher risk are rigid all-or-nothing thinking, inability to see different options, and perfectionism. Environmental factors. Recent theories of suicide focus on the diathesis stress model and a lethal combination of suicidal fantasies accompanied by loss, love, self-esteem, job, and freedom due to imminent incarceration, rage or guilt, and the identification with an individual who completed suicide, or a copycat. A copycat suicide follows a highly publicized suicide of a public figure, an idol, or a peer in the community. Adolescents are at an especially high risk due to their immature prefrontal cortex, the portion of the brain that controls the executive functions involving judgment, frustration tolerance, and impulse control. Cultural factors, including religious beliefs, family values, sexual orientation, gender identity, bullying behavior, and attitude toward death, have an impact on suicide rates. In 2013, ethnicity was a significant factor in the number of deaths by suicide in the United States. Suicide rate is the highest among whites. In 100,000 people, 11.7 American Indian and Alaska Natives, 6 Asian Pacific Islanders, 5.3 Hispanics, and 5.4 African Americans die by suicide. There's a little box here, suicide and bullying in Lgbt youth. We can read that later. Among African Americans, men completed suicide more often than women, and the peak rate occurs in young adulthood and middle age. Protective factors for this group as a whole include religion and the role of the extended family, both of which provide a strong social support system. Similarly, among Hispanic Americans, Roman Catholic religion, in which suicide is considered a sin, and the importance given to the extended family decrease the risk for suicide. There is also the philosophy of fatalismo, a belief that divine providence regulates the world. This philosophy removes the blame from the individual as unable to control adverse events. Risk factors for recent Hispanic immigrants are not understanding the U.S. healthcare system, fear of being deported, and language barriers. Among Asian Americans, suicide rates increase with age. Beliefs that reduce suicide attempts include the adherence to religions that emphasize interdependence between the individual and society, i.e., self-destruction is seen as disrespectful to the group or selfish. The high value given to the reputation of the family, however, may lead to the conclusion that suicide is preferable if it prevents shame to the family. A belief in reincarnation may make death a potentially honorable solution to life problems for the elderly in this population. Societal factors. Human beings are social beings that have evolved by banding together, yet our society is becoming increasingly isolated. Texting has replaced talking on the phone. People drive to work alone. Suburban neighbors frequently do not know one another's names. Urban dwellers know that making eye contact or talking to strangers is a taboo. Isolation sets the stage for loneliness and despair. In a more formal way, society regulates a specific suicide, namely assisted suicide. In the United States, individual states have the authority to regulate, allow, or prohibit assisted suicide. Increasingly, states are considering cases to determine the legality of assisted suicide. Other countries, including the Netherlands, Belgium, Switzerland, and Canada, have laws in place allowing physician-assisted suicide. The ethical and moral dilemmas in this evolving trend are clear. A really strange transition. Another societal concern is suicide bombing, which has grown exponentially since September 11, 2001. Suicide bombers believe, or are convinced by others, that it is an honor to die in defense of their faith. A real happiness exists beyond this life, and that for martyrs, dying is not real death, but an honorable entrance to the afterlife. Other risk factors. Risk factors for suicide include the following. Race. Caucasian suicides account for the highest percentage of completed suicides, approximately 85 to 90%. Caucasians have higher suicide completions than Asian, Pacific Islanders, or Hispanics. Religion. Religiosity is associated with decreased rates of suicide. Protestants and Jews have higher rates of suicide than Roman Catholics. Marriage. Being married, especially with children in the home, significantly reduces the risk of suicide. Divorced men are more likely than divorced women to kill themselves. Profession. Professions are generally considered at higher risk for suicide, particularly if there is a loss in status. Among professionals, physicians, dentists, veterinarians, and chiropractors are at highest risk. Law enforcement personnel, sales personnel, mechanics, insurance agents, and lawyers are also at higher risk. Over the past several years, there has been an increased risk in construction workers and heavy equipment operators. Physical health. Those individuals who have chronic illnesses are at increased risk of suicide. Loss of mobility, disfigurement, chronic pain are especially associated with suicide. Extensive data are available about risk factors for suicide. Based on epidemiological studies and psychological autopsies, i.e., retrospective reviews of the deceased person's life within several months of death to establish likely diagnosis at the time of death. There is also evidence concerning protective factors, those that tend to reduce risk. Box 25.2 provides description, significant psychosocial risk, and protective factors for suicide. Box 25.2. Warning factors, risk factors, and protective factors. Warning factors. Often talking or writing about death, dying, or suicide. Making comments about being hopeless, helpless, or worthless. Expressions of having no reason for living, no sense of purpose in life. Saying things like, it would be better if I wasn't here, or I want out. Increased alcohol or drug misuse. Withdrawal from friends, family, and community. Reckless behavior or more risky activities, seemingly without thinking. Dramatic mood changes. Talking about feeling trapped or being a burden to others. Risk factors. Previous suicide attempts. A history of suicide in the family. Substance abuse. Mood disorder. Access to lethal means. Losses and other events. History of trauma or abuse. Chronic physical illness, including chronic pain. Exposure to the suicidal behavior of others. Protective factors. Effective mental health care. Easy access to a variety of clinical interventions. Strong connections to individuals, family, community, and social institutions. Problem solving and conflict resolution skills. Contact with providers. Clinical picture. A history of suicide attempts puts a person at a high probability of actually completing suicide in the future, particularly in the 12 months following the attempt. Han and colleagues note that among those who attempted suicide in the past 12 months, only 56.4% received mental health treatment, and those who did not receive mental health treatment reported high rates of unmet treatment needs. Because suicide behaviors are often associated with other psychiatric disorders, especially major depression, the pathological features are similar. And similar treatment plans are appropriate no matter what other disorders present. You should direct your attention to individuals who exhibit these behaviors because of the serious outcomes that may result. Suicidal behavior disorder was proposed as a new disorder for DSM-5. Supporters for its inclusion believe that such a diagnosis would be a way of better identify and track individuals who are at greatest risk for suicide. Opponents of adding the disorder argue that such a label is unnecessary since diagnosing associated conditions such as major depressive disorder already provided a way to identify and track risk. In the end, suicidal behavior disorder was voted down. But what was added to the manual is a section called Conditions for Further Study. Application of the nursing process. Suicide risk assessment is based on identifying specific risks and protective factors, taking a psychological and health history, and establishing a therapeutic relationship with the patient during the interview. The nurse usually completes the assessment in conjunction with other clinicians because comparison of data and impressions from 2 or more interviews can result in a more comprehensive evaluation. Assessment. Assessment tools are helpful in providing a baseline evaluation that can be compared over time. One assessment tool that encompasses both risk and protective factors provides a clinician with a tool to benchmark risk and suggest interventions in the suicide assessment 5-step evaluation and triage, SAFE-T. This tool was established because on sponsored research outcomes from the Substance Abuse and Mental Health Service Administration, a free pocket guide can be downloaded from Psychobiological. The tool allows a clinician to benchmark relative risk, high, moderate, low, and to develop a treatment plan in consultation with the patient to reduce current risk. Verbal and nonverbal cues. Individuals considering suicide usually provide some clues to their intent, especially to people who are supportive to them, such as nurses. These clues come in the form of open messages, also known as overt statements, or in a concealed manner known as covert statements. Additionally, the nurse should teach family members and other support people in the community regarding these statements that may indicate risk. Examples include the following. Overt statements. I can't take it anymore. Life isn't worth living anymore. I wish I were dead. Everyone would be better off if I died. Covert statements and nonverbal clues. It's okay now. Soon everything will be fine. Things will never work out. I won't be a problem much longer. Nothing feels good to me anymore and probably never will. How can I give my body to medical science? Ugh. Most often, it is a relief for people contemplating suicide to finally talk to someone about their despair and loneliness. Asking about suicidal thoughts does not give a person the idea to commit suicide. Asking is, in fact, a professional responsibility similar to asking about chest pain in cardiac conditions. Talking openly leads to a decrease in isolation and increased problem-solving alternatives for living. People who contemplate suicide, attempt suicide, and even those who regret the failure of their attempt are often extremely receptive to talking about their suicide crisis. Specific questions to ask about suicidal ideation include the following. Have you ever felt that life is not worth living? Have you been thinking about death recently? Do you ever think about suicide? Have you ever attempted suicide? Do you have a plan for completing suicide? If so, what is your plan for suicide? The following dialogue illustrates how the nurse can make covert messages more open. Nurse, you haven't eaten or slept well for the past few days, Teresa. No, I feel pretty low lately. How low are you feeling? Oh, I don't know. Nothing seems to matter to me anymore. It's all so meaningless. Tell me about it, Teresa. I want to understand how you're feeling. What is meaningless? Life, the whole thing, nothingness. Life is a bad joke. Are you saying you don't think life is worth living? Well, yes. It's all so hopeless anyway. Are you thinking of killing yourself? Oh, I don't know. Well, sometimes I think about it. I probably would never go through with it. Teresa, let's talk more about what you're thinking and feeling. This is important. I'll need to share your thoughts with other members of the staff. The nurse should be alert for non-verbal behavioral clues, including showing a sudden brightening of mood with more energy, especially after recently being prescribed an antidepressant medication, giving away possessions, writing letters, or organizing financial affairs. Individuals may be at greater risk as their mood lifts because they have enough energy to act on their feelings of ambivalence regarding suicide. The risk of suicide is highest in the first year after a suicide attempt. Establishing a therapeutic relationship with the patient and asking directly about suicidal feelings are essential elements of the nurse-patient relationship. Asking about suicidal ideation is the single most important assessment and intervention. Possible reasons for hesitancy in screening include lack of personal comfort, lack of professional confidence, and time constraints. Crisis intervention techniques involve listening for the emotional feeling message underlying the verbal message, especially when the patient presents an angry, hostile, and overwhelmed. The therapeutic alliance established for the patient is a dynamic, changeable interaction. Thus, you should be constantly assessing and documenting it. Lethality of suicide plan. The evaluation of a suicide plan is extremely important in determining the degree of suicidal risk. There are three main elements to consider when evaluating lethality. Is there a specific plan with details? How lethal is the proposed method? Is there access to the planned method? People who have definite plans for the time, place, and means are at highest risk. Based on the lethality of a method, which indicates how quickly a person would die by that mode, you can classify the method as higher or lower risk. Higher risk methods, also referred to as hard methods, include using a gun, jumping off a high place, hanging, poisoning carbon monoxide, staging a car crash. Examples of lower risk methods, also referred to as soft methods, include cutting one's wrist, inhaling natural gas, ingesting pills. When the patient confirms access to the proposed method, the situation is more serious. A man who has access to a high building and states that he will jump from it, or a woman who has a gun and says that she will shoot herself, is at serious risk for suicide. People are experiencing psychotic episodes. They are also at high risk, regardless of the specificity of details, because impulse control and judgment are grossly impaired. Persons suffering psychosis, particularly vulnerable and depressed, are having command hallucinations. Self-assessment. Healthcare professionals working with individuals who are suicidal need collaboration with other clinicians. Fear, grief, anger, puzzlement, condemnation of suicidal feelings, and intent are common emotions experienced. If these intense emotional responses are not acknowledged, countertransference may limit effective intervention. Understanding the patient with suicidal behavior disorder, as well as acknowledging, understanding, and accepting emotions that arise from working with caring for these patients is essential. Diagnosis. The nursing diagnosis with the highest priority is risk for suicide. Feelings of hopelessness, anger, frustration, abandonment, and rejection are common among people who are suicidal. Nursing diagnosis that address problems related to depressed mood, anxiety, mania, or disturbed thought include self-care deficit, sleep pattern disturbance, altered nutrition, and anxiety. See the clinical chapters focusing on depressive disorders, bipolar disorders, schizophrenia spectrum disorders for more information. Outcome criteria. Relevant nursing outcomes classification. Outcomes include suicide, self-restraint, coping, hope, self-support, spiritual health, and self-esteem. Table 25.2 describes signs and symptoms, potential nursing diagnoses, and outcomes for suicidal behavior. That's a nice big table. We can look at that later. Planning. Plan of care for a patient who is suicidal is based on risk and protective factors. When there is a comorbid psychiatric disorder, the treatment plan includes appropriate nursing approaches, e.g., care for patients with depression or schizophrenia. The patient's significant others need to be involved because the patient's perception of isolation is a significant cause of hopelessness. Intervention. Nursing interventions for patients with suicidal ideation and suicide attempts focus on prevention, treatment, and post-vention. Improving overall community mental health services may reduce the incidence of suicide more effectively than extensive efforts directed at identifying individuals who are imminently suicidal. Therefore, more attention focused on prevention that involves community-wide participation will lead to improved outcomes. Prevention is a primary intervention and includes activities that provide support, information, and education to prevent suicide. Primary intervention is practiced in a wide variety of community settings such as schools, homes, churches, clinics, hospitals, and work settings. Elementary school children are screened using evidence-based tools that focus on both risk factors and warning signs. High schools are adopting suicide prevention curricula that involve elements of education, peer support, discussions about risk and prevention factors, and warning signs. Nurses can learn about suicide prevention through the Question, Persuade, Refer model, QPR. This model, originally developed in 1995, is a simple educational train-the-trainer program, provides ordinary citizens with education about how to recognize a mental health emergency, get individuals at risk the help they need, and provide hope through the process. The case study and nursing care plan represents a case of a young man with suicidal ideation treated in an outpatient setting. All right, there's a big old case study here. It takes up the whole page. You can read that later. And we have box 25.3, Goals of the National Strategy for Suicide Prevention. Integrate and coordinate suicide prevention activities across multiple sectors and settings. Implement research-informed communication efforts designed to prevent suicide by changing knowledge, attitudes, and behaviors. Increase knowledge of the factors that offer protection from suicidal behaviors and that promote wellness and recovery. Promote responsible media reporting of suicide, accurate portrayals of suicide and mental illness in the entertainment industry, and the safety of online content related to suicide. Develop, implement, and monitor effective programs that promote wellness and prevent suicide and related behaviors. Promote efforts to reduce access to lethal means of suicide among individuals with identified suicide risk. Provide training to community and clinical service providers on the prevention of suicide and related behaviors. Promote suicide prevention as a core component of healthcare services. Promote and implement effective clinical and professional practices for assessing and treating those identified as being at risk for suicidal behaviors. Provide care and support to individuals affected by suicide deaths, and attempt to promote healing and implement community strategies to help prevent further suicides. Increase the timeliness and usefulness of national surveillance systems relevant to suicide preventions, and improve the ability to collect, analyze, and use this information for action. Promote and support research on suicide prevention. Evaluate the impact, effectiveness of suicide prevention interventions and systems, and synthesize and disseminate findings. Psychosocial interventions. The key element is establishing a therapeutic alliance to encourage the patient to engage in more realistic problem solving. Helpful staff characteristics include warmth, sensitivity, interest, and consistency. After hospitalization, nurse may work with these patients in the clinic, in a partial hospitalization program, or in-home care. One particular aspect of counseling is the use of patient safety plan. This is a written 6-step plan that includes identification of warning signs, internal coping strategies, social settings, and people who provide distraction. It also provides instructions on people who patients can ask for help, professionals or agencies where they can find help during a crisis, and how to make the environment safe. Additionally, this written safety plan asks the patient to identify something most important to them worth living for. Psychobiological intervention. Pharmacological interventions are used to alleviate symptoms of comorbid disorders. Antidepressants are used for patients who have a depressive disorder or an anxiety disorder. Close monitoring must occur, especially when patients begin medication and when the dosage changes. Strong nursing care involves a careful patient and family, if appropriate, teaching about the benefits and risks of antidepressant therapy. There is clear evidence that long-term lithium treatment for bipolar disorder and major depression significantly reduces suicide and suicide attempts. Because lithium frequently causes serious side effects and necessitates periodic blood work to test for these therapeutic levels, patient and family education is important to support adherence. For patients experiencing psychotic or bipolar manic episodes, antipsychotic medication is usually ordered. Second-generation antipsychotics are preferable to first-generation antipsychotics because they have fewer adverse effects. Some studies have shown a reduced suicide rate among patients with schizophrenia receiving clozapine, Clozaril. Monitor the use of clozapine closely, however, because of the risk of severe side effects, e.g., agranulocytosis, myocarditis, and altered glucose metabolism. Finally, anti-anxiety medication may help treat risk factors such as severe anxiety, panic, and agitation. Aggressive treatment of anxiety beyond antidepressants is advisable based on current research. A significant nursing intervention to assist the patient with suicidal ideation, regain self-control, and the careful administration of medication. Medications prescribed to high-risk patients are monitored carefully. Lethal overdose is nearly impossible with the newer antidepressants, such as SSRIs. Overdose remains a concern with tricyclic antidepressants and MAOIs. Mouth checks may be used to be sure the patients are not hoarding medications in the hospital. In the community, provision of a limited day supply or family supervision is required. Somatic intervention. An alternative somatic treatment for acute suicidal risk is shock therapy, ECT. Evidence suggests that ECT decreases acute suicidal ideation. This treatment is useful for patients with depression or psychosis whose behavior is considered life-threatening and for whom waiting for medication to take effect is not feasible. It is also safe and effective for pregnant patients, patients with certain medical conditions who cannot tolerate medication, and patients who do not respond to multiple trials of medication. Refer to Chapter 14 for further discussions of ECT. Health teaching and health promotion. The nurse teaches the patient about psychiatric diagnosis, medications, and complementary therapies, the age-related developmental crises. Teaching is also important regarding community resources, coping skills, stress management, and communication skills. Additionally, teaching regarding development of a safety plan is important in the prevention of suicide. When possible, including the family or significant others to strengthen the patient support system. Here we have a patient safety plan template, which is a good thing to look at. Case management is an important aspect of nursing care for the patient with suicidal ideation. The patient's perception of being alone, without supports, often blinds them to the real support figures who are present. Reconnecting the patient with family and friends is a major focus, whether in the hospital or community. Aftercare referrals may include information on the following resources: treatment providers, substance treatment centers, crisis hotlines, support groups for patients or families, and recreational activities to enhance socialization and self-esteem. Encouraging the patient to get reacquainted with a previous spiritual support system may also be beneficial. Milieu therapy. Nurses play an important role in the treatment of patients who are at risk, those who have suicidal ideation, and those who have made a suicide attempt. In the hospital or community setting, the registered nurse utilizes psychosocial and psychobiological interventions, safety and teamwork, health teaching, and case management to provide care to patients who have suicidal ideation or have attempted suicide. An interprofessional approach that emphasizes communication involving clinicians, nurses, social workers, therapists, counselors, and support persons is essential for reducing the number of suicides. This collaborative approach maximizes patient safety and improves outcomes through timely communication and improved coordination of care. For patients with acute suicidal intentions, suicide precautions, according to the accordance with hospital policy, are part of the plan of care. Nursing staff must continuously observe patients who are suicidal. Table 25.3 provides a general description of suicide precautions. 25.3. Suicide precautions with constant one-on-one observation. Staff assessment patient with suicidal ideations or delusions of self-mutilation who, according to assessment by unit staff, presents clinical symptoms that suggest a clear intent to follow through with the plan or delusion. That's a very long sentence. Possible patient symptoms. Patient is currently verbalizing a clear intent to harm self. Patient shows no insight into existing problems. Patient has poor impulse control. Patient has already attempted suicide in the recent past by a particular lethal method: hanging, gun, carbon monoxide. Nursing responsibilities. One-to-one nursing observation and interaction 24 hours a day. Never let the patient out of staff sight. Chart patient's whereabouts and record mood, verbatim statements, and behavior every 15 to 30 minutes per protocol. Ensure that meal trays contain no glass or metal silverware. When patient is sleeping, hands should always be in view, not under the covers. And observe the patient swallow each dose of medication. Monitoring flow sheets for suicide precautions is more clinically useful if they include a description of the patient's affect and behavior. For example, instead of noting patient watching television, the nurse will describe the patient's affect: hostile, fearful, calm, at each observation. Flow sheets should also indicate clear accountability for staff starting and ending the periods of observation. In addition to observing the patient, the nurse is responsible for monitoring the patient, the environment, for safety hazards. Review Box 25.4 for guidelines on how to minimize physical risks in the environment. Box 25.4, environmental guidelines for minimizing suicidal behavior on the psychiatric unit. Use plastic utensils and cup utensils when the tray is collected. Do not assign a patient to a private room, and ensure the door remains open at all times. Jump-proof and hang-proof the bathrooms by installing breakaway shower rods and recessed shower nozzles. Keep electrical cords to a minimal length. Install unbreakable glass in windows. Install tamper-proof screens or portions too small to pass through. Keep all windows locked. Lock all utility rooms, kitchens, adjacent stairwells, and offices. All non-clinical staff, housekeepers, maintenance workers, should receive instructions to keep doors locked. Take all potentially harmful gifts, flower and glass vases, from visitors before allowing them to see patients. Search all items brought to patients by visitors. Go through personal belongings with patient present and remove all potentially harmful objects: belts, shoelaces, metal, nail files, tweezers, matches, razors, perfume, and shampoo. Ensure that visitors do not bring in or leave potentially harmful objects in the patient's room. Search patient for harmful objects, drugs, sharp objects, cords, if allowed to leave unit on pass. Studies show that acute care of patients who are suicidal is usually effective. Suicide risk is highest in the first few days of hospital admission and during times of staff rotation. Assessment of suicidal risk must be an ongoing process. You should perform an assessment particularly before a change in level of observation or upon sudden improvement or worsening of symptoms. Documentation of care. As for documentation, you must ensure that the record is complete and identify any late entries. Courts require that the patient be periodically evaluated for suicidal risk, that the treatment plan provide for high-level security, and that staff members follow the individual treatment plan. Despite following institution protocols, treatment plans, and the appropriate standards of practice, suicides do occasionally still happen. This is especially the case for patients in the community. Human behavior is simply not predictable. Preventing veteran suicide. The VA reports that approximately 22 veterans end their lives by suicide every day. Many of them are unemployed, socially isolated, homeless, or struggling with addictions. These problems are most often connected to PTSD following deployment to Iraq or Afghanistan. In an extraordinary demonstration of bipartisanship, both the House and Senate unanimously passed the Clay-Hunt Suicide Prevention for American Veterans Act, and President Obama signed the bill into law February 13, 2015. The bill was named in honor of Clay Hunt, a Marine veteran who ended his life in 2011 after struggling with PTSD. Although he sought help for his illness, he waited more than 6 months to see a psychiatrist. The bill provides for independent reviews of the DoD's programs to prevent suicides and creates peer support, community outreach, pilot programs. Due to the shortage of psychiatric clinicians, the legislation provides loan debt repayment for psychiatry students who choose to work in the VA health system. Additionally, through resources provided by the legislation, a website was created that provides information about mental health services to veterans and allows the VA to collaborate with other organizations in efforts to prevent suicide. It's pretty cool. Post-Vention. Survivors of suicide, the circle of survivors of a person who has completed suicide, are the largest group of mental health casualties related to suicide. Surviving family and friends may experience overwhelming guilt and shame compounded by the difficulty of discussing the frequently taboo subject of suicide, sadness, loneliness, abandonment, and disbelief. Adolescents who suffer traumatic grief after a friend's death by suicide are more likely to report suicidal ideation within 6 years of the suicide. Family members of individuals who complete suicide develop a 4.5 times greater risk of suicide than those in the families in which no suicide occurred. Despite their suffering, only approximately 25% of survivors seek treatment. Adults bereaved by suicide have a higher probability of attempting suicide than individuals bereaved by sudden natural causes of death. Based on a statistic that there are 6 survivors per suicide completion, there are more than 6 million Americans who are considered survivors in the U.S. during the past 25 years. There's a little box here that I'm not going to read. One survivor wrote a personal account several years after the suicide of her daughter. If only I hadn't responded with anger and frustration during our last phone call. She was angry with herself and seemed to want to pick a fight with me, which was the pattern. If I could have looked past her angry words and instead turned into the desperation behind them, maybe I could have gotten her to open up to me. Now I can only look back and consider the many, many times I should have picked up on the severity of her illness and how she struggled. If I have any advice for others based on my experience, it is to get connected, listen, and be a real part of the lives of those you love. That's the only way you'll know when something is just not right and understand their deep despair. This also applies to friends and families of survivors. Please don't treat us like we're contagious, and please do talk about our loss. The worst thing possible is to avoid mention of our lost loved one. Healthcare providers are often involved in providing mental health care and support to these survivors, which is referred to as Post-Vention. Survivors have given the following suggestions to healthcare professionals. If being a survivor is the main reason an individual seeks treatment, remember that the survivor, not the deceased, is the patient. Focus on the patient's thoughts and feelings, and do a thorough assessment as you usually would. If you are a friend or relative of a suicide survivor, remember that the most difficult time for these survivors is not so much in the immediate aftermath of the suicide. Rather, it is in the weeks, months, and years following their loss. Make frequent effort to reach out to these individuals, especially on the most difficult anniversary dates. Do not be afraid of talking about the deceased person. In fact, speak of them often. While this may seem counterintuitive and uncomfortable for most, survivors of suicide universally want their loved ones to be remembered in this way. Talking reduces the hurt, isolation, and stigma. If being a survivor comes out as an incidental finding during an assessment, ask open-ended questions and evaluate how much the loss has been resolved. Recommend community resources and survivor support groups and show empathy about the loss of someone to suicide. Know about local survivors of suicide SOS support groups in your area, and refer the survivors and their families as soon as possible following the suicide. Staff members who have cared for a patient who completed suicide within the treatment facility are similarly traumatized by suicide. Staff may also experience symptoms of post-traumatic stress disorder with guilt, shock, anger, shame, and decreased self-esteem. Group support is essential as the inpatient treatment team conducts a thorough psychological postmortem assessment. The team will carefully review the events to identify the potential overlooked clues, faulty judgments, or changes that are needed in agency protocols. Most facilities have a clear policy about communication with families after suicide. Although some lawyers advise having no contact except through them, others recommend designating a spokesperson that can address the feelings of the family without discussing the details of the patient's care. Giving referral to family members to assist them in dealing with their grief and to address any emotional problems that develop, especially in adolescence. Advanced Practice Interventions. The Psychiatric Mental Health Advanced Practice Registered Nurse may treat patients with suicidal ideation directly with psychotherapy, psychobiological interventions, clinical supervision for direct care staff, or consultation in non-psychiatric settings, e.g. healthcare unit, nursing home, or forensic site. Following hospitalization, the advanced practice nurse may provide aftercare for the patient who has coexisting psychiatric disorders. This care includes individual and family therapy and medication management. Evaluation. Evaluation of a patient with suicidal ideation is ongoing. The nurse must be constantly alert to changes in mood, thinking, and behavior. The nurse also looks for indications that the patient is communicating thoughts and feelings more readily and that the patient's social network is widening. If the person is able to talk about feelings and engage in problem solving with you, this is a positive sign. Suicidal behavior is the result of interpersonal turmoil. If an episode of major depressive disorder is the main admitting diagnosis and a serious suicidal gesture resulted from this depression, both problems are initially assessed and treated. When the patient is no longer an acute suicide risk, treating the suicidal ideation and depressive disorder becomes the main focus of care. Essentially, the nurse evaluates each short-term goal and establishes new ones as the patient progresses towards the long-term goal of resolving suicidal ideation. Once stabilized, the patient may be admitted to a partial hospitalization program. PHPs tend to be 6 hours a day, 5 days a week. An intensive outpatient treatment program is another slightly shorter option, usually 3 hours a day, 3 days a week. Both the PHP and IOP allow patients to go home in the evening to practice new coping skills. Community-based support groups are also available that are effective and financially affordable for the patient. Nurses should be knowledgeable about and proactive in referring patients to these support groups. Non-suicidal self-injury. A closely related problem to suicidal behavior is non-suicidal self-injury. These self-injuries are deliberate and direct attempts to inflict shallow yet painful injuries to the surface of the body without intending to end one's life. The behavior most commonly consists of cutting, burning, scraping, scratching skin, biting, hitting, skin picking, and interfering with wound healing. Often the self-injurers report multiple methods of self-injury. For these behaviors to be considered significant, they typically last at least a year and happen repeatedly. The majority of self-injurers do not seek professional help. Even when they are not engaged in the behaviors, self-injurers tend to be thinking about self-injury. Self-injurious actions are most often done with the intent to either alleviate psychic pain or to pierce the psychic numbness these individuals describe. Other times, these actions are used to punish themselves, to connect with others, to get attention, to escape responsibility, or to avoid a situation. Epidemiology. The lifetime prevalence of non-suicidal self-injury is difficult to accurately determine due to attempts to conceal the behavior. However, some have estimated that between 13% and 23% of adolescents engaged in the behaviors. It is a global problem, peaking between 20 to 29 years of age, with 17 to 35% reporting engaging in this behavior. There is a decline in the behavior beyond this age. Estimates are that approximately 6% of the U.S. population has engaged in the behavior some time in their life. Research regarding prevalence by gender is inconclusive. Some studies report there is less discrepancy between the sexes than there is suicidal behavior. Comorbidity. Non-suicidal self-injury often occurs with other mental health disorders, including depression, anxiety, eating disorders, and substance use disorders. In the past, researchers thought there was a direct relationship between borderline personality disorder and non-suicidal self-injury. However, Bracken-Minor and McDevitt-Murphy conducted research and concluded that the emotional regulation and distress tolerance found in individuals with non-suicidal self-injury, or NSI, was distinctly different from characteristics found in borderline personality. Risk factors. Studies related to the physiological mechanism of action in NSI are inconclusive. However, researchers continue to investigate the neurobiological mechanism behind the disorder. Several neurochemical pathways in the brain play a role in the development of these behaviors. Although studies are inconclusive, the neurotransmitter group of monoamines, including serotonin, dopamine, and norepinephrine, may play a role in the mediation of self-injury, and research is ongoing. As practitioners continue to search for an effective treatment, clinical research will seek to find the neurobiological basis of NSI. Environmental factors. Recent studies have investigated the prevalence of NSI behaviors internationally to determine best practices for treatment and whether culturally different approaches to care are relevant. Similar rates of the behavior occur among adolescents in the United States and among several European countries, with the behavior stabilizing among youth over the past several years and no significant increases internationally. With the stabilization in occurrence rates, researchers have opportunity to further investigate cultural differences in the behavior and whether these differences lead to different treatment modalities. Societal factors. Self-injurious behaviors such as cutting may be a social phenomenon that is rampant in society. Individuals often learn about the behavior from a peer who is engaging in NSI and begin using the behaviors themselves in an attempt to alleviate personal discomfort. In fact, after an individual who engages in NSI is admitted to an inpatient unit, others on the unit begin to engage in the behavior. Clinical picture. NSI is not an official disorder in the DSM-5. It is still under review to determine whether it will become a recognized disorder by the APA. However, the behaviors associated with the disorder are often seen in both inpatient and outpatient settings. Application of the nursing process. Assessment. A history from the patient regarding the self-injurious behavior includes types of self-injury, triggers for the behavior, and frequency of the behavior. Additionally, ask the patient what has worked effectively in stopping the behaviors in the past. Appropriate physical assessment to determine the condition of wounds if present allows you to plan appropriate interventions. Self-assessment. Nurses caring for patients who engage in self-injury report that they are emotionally affected by caring for these patients. Emotions experienced include feeling defeated by relapses, discouragement, and powerlessness. Additionally, nurses need to be aware that transference may occur through projection of the patient's emotions onto the nurse. Establishing appropriate professional boundaries with the patient is important for self-care, as is collaboration with clinicians. Diagnosis. The nursing diagnosis with the highest priorities are self-mutilation and risk for self-mutilation. Patients may be experiencing feelings of anxiety, tension, and self-reproach. Consider any nursing diagnosis that is appropriate for underlying comorbid psychiatric as appropriate. Outcomes criteria. The relevant NOC is mutilation self-restraint, which is defined as personal actions to refrain from intentional self-inflicted injury. Measurements for this outcome include refrains from gathering means for self-injury, obtains assistance if needed, refrains from injuring self, uses available support groups, uses medication as prescribed, uses effective coping strategies. Planning. Plan of care for individuals who engage in self-injury includes demonstration of a caring attitude towards the patient, bringing hope for recovery, observing for signs of self-harm, evaluating the need for medication, and providing appropriate interventions for patients' wounds and injuries. Engage patients in their recovery plan, which encompasses a 6-step approach to recovery, including 1. Limit setting for safety, 2. Developing self-esteem, 3. Discovery of the motive for self-injury and the role served for the patient, 4. Learning that self-injury can be self-controlled, 5. Replacing the self-injury with coping skills, and 6. Entering a maintenance phase. Interventions. Basic nursing interventions for patients with non-suicidal self-injury include caring for the patient's wounds and injuries, establishing a therapeutic alliance, and teaching coping skills to replace the self-injurious behaviors. A therapeutic relationship will provide support and alternative to self-injury when anxiety increases. Advanced practice psychiatric mental health nurses may work with patients who use self-injury to cope. Currently, there are no evidence-based practices for treating this disorder. Psychotherapeutic interventions for this population to facilitate patients' ability to learn coping strategies. Specific therapies that are used including CBT, dialectical behavioral therapy, and group therapy. Treating underlying psych disorders using psychopharmacology is an additional role of the advanced practice nurse. Valuation. Similar to suicidal behavior, the evaluation of patients with NSI behaviors is ongoing. The development of a therapeutic alliance with the patient allows the patient to trust a care provider. The nurse must continue to evaluate whether the patient is communicating his or her thoughts and feelings accurately and whether the patient's perception is that engagement in these behaviors is declining while being replaced with appropriate coping skills. And that is it for that one. Right in at under an hour. And there you have it.